Good evening, friends. Welcome to this month's edition of Secure Foundation lecture series. We've had two previous lectures in this series. The series is mainly aimed at surgeons who are beginning to start their practice into subspecializing in arthroplasty. For now, we are dealing with arthroplasty related topics, and also to brush up the latest techniques for the seniors. So the first lecture was by Dr. Arun Kannan. The second lecture was elegantly conducted by Dr. Rajkumar. And today we've got another eminent arthroplasty surgeon from Chennai, Dr. Bharath. He's undergone extensive training in arthroplasty and is very experienced in hip and knee arthroplasty surgeries. He's going to talk to us about valgus knee, which is again a very common problem we see in our day-to-day practice. Though varus knee is our daily case, there is a valgus knee often in the list, and then sometimes we are confused as to how to deal with it. And to add to the panel discussion, we have none other than Dr. DrBRJSathish, who's a very senior orthopedic surgeon from Coimbatore, whose article about valgus knee has been published in Journal of Bone Joint Surgery. He's a very senior orthopedic surgeon. So thank you very much for joining us, sir, in the panel. We'll also have Dr. Arun Kannan and Dr. Kowshik to contribute to cases. I invite other doctors who actually joined the panel and joined the Zoom link. You can raise questions if you have any. So I hand over the podium to Dr. Bharath now.
Good evening, everyone. Thank you, Dr. Karthik Selvaraj. Thank you for the kind introduction. Is it audible? My voice is audible?
I think you have to be a little louder.
Yeah. Is it audible now?
Yeah, audible for me.
Okay. So I will go and share my screen. Able to see?
Yes.
Is it a full screen, Karthik?
No, not full screen. You have to.
Okay. Now is it okay?
Yes. Yeah.
Okay.
Not full screen.
Dr. Karthik, thank you once again. And good evening, DrBRJSathish sir. Recently we met in TUNICON, I think so.
Yeah.
Yeah, sir. Karthik, shall I proceed? Start to see.
Yes.
So the topic what was given to me was an algorithmic approach to TKR in a valgus knee. So before discussing about details of the surgical tips and tricks, it is necessary to understand the basic pathoanatomy, what is happening. So when we say valgus knee is completely different, the pathoanatomy is completely different from the varus knee. So the valgus knee is a multiplanar dynamic deformity, which requires 3D orientation of bone and soft tissues. If at all, if the valgus is fixed and more than 10 degrees, it proposes a challenge to the surgeon. So what we anticipate in a valgus knee and what are the complications that we expect before addressing these are like peroneal nerve palsy, patellar maltracking, and flexion and extension instability. To understand this deformity, in valgus knee, the bone loss is more common on the femoral side, mostly on the distal and on the posterior condyle. Whereas in contrast to the varus knee, where the defect is more on the tibial side. And if at all, if you find a defect on the tibial side, and most of the time they are contained. The reason for containment is because of the fixed the bony structure of the fibula head, which allows uncontainment of the tibial defect, and other dynamic structures like IT band and your popliteus, which will prevent your uncontainment. And of course, the patella is thinned out laterally and slowly starts subluxating on the lateral side. Whereas considering the soft tissue, the medial structures are completely stretched out depending upon the degree of the deformity. And the lateral structures like IT band, the lateral capsule, the posterolateral capsules, and popliteus and late and at last the LCL is also contracted over the period of time. And this degree of contractions depends upon your sagittal plane deformity also. So what the major problem is in identifying the bony landmarks because the bony anatomy is distorted. It is difficult to identify our epicondylar axis. The trochlear depth cannot be measured for white side line. And even if you wanted to go for a fixed 3 degrees external rotation, shall I proceed? Karthik?
Yeah, you can continue.
OrthoTV, it says the recording is stopped. Is there any problem?
I think the OrthoTV guy is not here.
Oh. Just no, you can proceed, no problem.
Okay. That's it. The major problem here is identification of the bony landmarks because most of the time the anatomy is distorted. The epicondylar axes are difficult to identify. The depth of the trochlear knots can't be measured, so white side line is not possible. And if at all you wanted to use your fixed 3 degree external rotation, then because of the hypoplastic, the posterior condyle, you might end up with internal rotating your femur. So how to balance your knee in flexion? It is by a tibial parallel technique. Most of the time you require a gap balancing technique to balance your knee in flexion. So coming to the most common working classification, or it was proposed by Ranawat, even though we have many classifications, but the common working classification by Ranawat is type 1 when your valgus deformity is less than 10 degree, correctable, and if your MCL is completely intact. Type 2 when your deformity is more than 10 to 20 degrees, and MCL is attenuated but has a firm endpoint on giving a valgus strain. Whereas in type 3, the MCL is completely more than 20 degrees of valgus and the MCL is completely attenuated, or you can consider it as absent. It's completely giving away on the medial side. But why is this grading scale important? One is to determine the amount of correction required, the extent of soft tissue release to be done, and of course, what type of implant, the constraint, whether you want to go for a CR cruciate retaining knee, a posterior stabilized, a semi-constraint, or you want to go for a complete constraint knee. So, but the principles of TKR remains the same. One have to concentrate on restoring the frontal alignment in all 3 planes, restore the joint line, restore joint stability, and of course, restore the patellofemoral kinematics and range of motion. And of course, one have to use appropriate fixation techniques to end the procedure. So to coming to the tips, first is to restore the frontal alignment. So how to restore the frontal alignment? This lecture is completely for those who are doing by the manual technique using intramedullary and extramedullary jigs. So preferably take a proximal tibial cut at 90 degrees, that is parallel to your joint line, parallel to your ankle, and preferably make an entry on the medial side of than your routine entry. The reason for it, the medialmost entry is because the anatomical axis is the medial entry is going to be parallel to anatomical axis because of the valgus remodeling of the fibers over a period of time. And of course, when performing a distal femoral cut, your preferred valgus correction angle is about 2 to 4 degrees is required, so that can counteract your valgus forces upward. Here you can appreciate the hypoplastic lateral condyle even after a sufficient distal femoral cut. So
Sunday on the micro.
The first step, the key step is to balance your knee in extension by adequate release of your lateral structures. And the extension balancing is purely a soft tissue balancing. So whether to release your IT band or whether you release your posterior capsule, it's all going to depend upon your sagittal plane deformity, which we are going to discuss lately. So gap balance your knee inflection, as I already told, it is preferably by a tibial parallel technique as described by Ranawat. Preferably avoid soft tissue release to balance your knee flexion. Coming to bony cuts, if it is a type 1 valgus, when your MCL is completely intact and there is no medial opening, it is always preferred to go for a standard bony cuts, approximately what the company indications, whether to 9 or 10 mm of your standard cuts. Suppose if you find an X-ray with a type 2 or type 3 valgus with a significant amount of medial opening and they are correctable, it is always advisable to go for a minimum bony cuts either on the tibia or on the femur also. So there are different methods of correction which has been proposed by different authors from late 70s. That is, it was proposed by Ranawat, it was proposed by Insal, Scott, Krakos. But various attempts like either longitudinal release of your complete retinaculum, transverse section of your IT band, picasting of your IT band, release of your posterior capsules. N number of techniques have been proposed, but of course, one particular technique is not going to work in that particular knee. So lately, what was much popular technique was Ranawat inside out technique. The order of release is the knee is completely placed in an extension with the laminar spreaders, and the order of release is from the PCL, posterolateral capsules, avoiding your popliteus, coming up to your posterior body of an IT band, and at last the IT band is picasted with a 11 number knife. This was the technique which was proposed by Ranawat, and it was quite popular. So what was our algorithm is, first is always necessary to identify the degree of valgus. Second is to know whether the valgus is correctable or whether it is rigid under anesthesia. And your sagittal plane deformity is going to determine which structures you're going to release on the lateral side first, whether it is going to start from IT band and then you go to your posterolateral capsule, or whether you are going to start with your posterolateral capsule and then coming up with your up to the IT band. Of course, one have to assess the status of your MCL. That is going to determine the level of constraint processes. When coming to the approaches, as we all know, approaches, a valgus knee can be approached either to an anteromedial or an anterolateral approach, but most often, most commonly, most of the valgus knees can be addressed by the anteromedial approach. But anterolateral approaches have its own indications that we are going to discuss later. Coming to the choice of implant, the posterior stabilized knee is the better choice because most of the valgus knees, there is going to have an extensive soft tissue release that is going to leave your knee unstable. So a PS knee is a safer compared to your CR knee. And if at all, if you have a suspicion of your MCL is attenuated or an absent, it is always one have to have an hinge on table. So this is an example of a type 2 valgus. The standing X-ray could show a significant amount of opening, but with a start on with the case, go for a minimal resection of the tibia and the femur, and your soft tissue release on the lateral side, adequate soft tissue on the lateral side is going to balance your knee with a minimal size of an 8 number insert in this particular case. This is another case with a minimal resection, type 2 valgus, minimal resection of the tibia and the femur with the adequate inside-out technique as described by Ranawat. We are able to balance this knee with a PS 8 number insert. This is also another case of type 2 knee balanced with a PS knee. So this is a case of a rheumatoid arthritis female with a rigid varus more than 30 degrees. We could see patella subluxating but not completely subluxated. You could appreciate the true valgus of more than 30 degrees. Once the tibia, we have tried to subluxate the tibia, one could appreciate a significant bony defect. Contained, it was about to get it uncontained. And you can see the distal femoral, the lateral condyle is completely hypoplastic. And this is the immediate post-op X-ray. Because of a small posterolateral bony defect, we have used a stem to address the bony defect. So, if at all, if you suspect or MCL insufficiency pre-operative, it is always better to have constrained the hinge implant. In this particular case, one could appreciate that the MCL is completely deficient, even preoperatively. Once the release is done on the medial side, the MCL is completely given away. So we have to use a hinge implant in the side. There are situations when valgus knees are associated with the neurological issues, and this is a case of polio with residual palsies where the quadriceps grade was almost up to 4/5. So we planned patient have an unstable knee. We plan to have a direct hinge processes to have a stable knee. So it is always, whenever you have a patient presences with a valgus knees, one have to keep in mind there is always a suspicion of some amount of neurological problem. Either it could be start from the spine or it could be such kind of a polio associated disease have to be always kept into mind. So there are situations we are not able to balance the knee completely, even in flexion and extension. At situations, this technique of sliding lateral condyle osteotomies helps to salvage the situations. So this osteotomy, you can avoid going for a higher constraint implants like PC3 or a hinge. So this is a well-described techniques, and if at all, if it is a rigid knee, non-correctable, and if at all you want to do it with a standard PS knee, this is a wonderful technique. And the lateral condyle osteotomy is fixed with a 2 or cortical canceller screws. And this case is a typical example for a lateral condyle osteotomies. And as we were discussing about the anterolateral approach, which was described by Kebrish, it has its own indications. Like when the valgus is more than 20 degrees and they are rigid, completely are partially not correctable, and if it is associated with flexion deformity, where you might have to approach that kind of cases with an anterolateral approach. And if at all, if a patella is completely subluxating or completely dislocated, this anterolateral approach. So the indications are quite clear. When the valgus is rigid, more than 20 to 30 degrees, with the flexion deformities and lateral subluxating or dislocating patella, it is always better to go for an anterolateral approach. So this is an example. Here, this is a case of a post-traumatic valgus knee with a flexion deformity, significant degree of valgus, complete rigid valgus, and of course, we have a plate in situ on the lateral side with the previous incisions. So the better option in this particular case to prefer an anterolateral approach. One is it's a fixed valgus deformity with a flexion deformity, and of course a lateral scar with the previous plate. So you can incorporate the knee replacement scar with the lateral scar so that the implant can be removed in one scar. So this is a short video of this same patient. One can appreciate this 72-year-old gentleman, the post-traumatic valgus knee with a lateral plate. You can appreciate the valgus, which is rigid with a flexion deformity, almost up to 15 degrees and further flexions to almost 100 to 130 degrees. Could see appreciate a lateral curvilinear scar. It's more fixed. So the scar, the previous scar is included with this incision. You can see the lateral retinaculum excised. The orientation is completely different from the medial parapatellar. This is the lateral parapatellar approach. One can appreciate the previous plate is exposed. Try to be as closer to the bone. The IT band is completely released up periostally. And you can see the lipping osteophytes indenting on the IT bands and the lateral capsule. Once release is done, it is always advisable to do a sequential release. Once you find the adequate release has been done, it is always better to recheck the amount of opening. There is a significant amount of opening at this stage of the lateral and the posterolateral release. The implant is removed from the same incision. The remaining tenting osteophytes are removed. At situation it is not possible to avert or subluxate patella on the medial side. That is one difficult step in an antero-lateral approach. The major benefit is you are addressing the pathology in its way. So this is the major advantage of doing the antero-lateral approach. The tibia is dislocated and the meniscus are removed. The tibial cut is made perpendicular to the ankle. The point is here it is difficult to design the rotation because of the complete lack of orientations. If a surgeon is new, you tend to completely external rotate your tibia. So it is better to use a floating technique at the end of the procedure to finalize your position of the tray. You could see the hypoplastic lateral condyle. The entry point is made medially. So it always to start with a minimal bony cuts. If required, you can go for a +2 cuts to balance the knee in extensions, because the standard teaching is once you have a type 2 or type 3 valgus, it's always to start with a minimal bone cuts. So, even though you start with a measured recession technique, but most of the time the landmarks, the anatomical landmarks are quite difficult to identify. So preferably the tibial parallel technique, and one can and the box cut is made. The posterior osteophytes are removed, and one could see a stable, and this knee was balanced with a normal PS implant. So the other advantage of this is it's a better patellar tracking because you're going to release your lateral retinaculum. So what are the demerits is sometimes if you release more laterally and the posterolaterally, you might end up with instabilities. The orientation is completely different for the surgeon and for the assistants. So you require a lot of experience before doing this procedure, the antero-lateral approach. And of course, the closure is going to be difficult. You might have to use your fat pad to close the defect of the lateral retinaculum. So to conclude, a fixed valgus deformity is a challenge because it is a dynamic deformity. Deciding femoral component rotation is the crux. Sequential releases should be readdressed every time and intermittently. Posterior stabilized process will provide a more reliable result. A well-balanced knee will have a good and excellent result. The choice of constraint implant should be always on your shelf. Beware of peroneal nerve palsies, instabilities, and patellar maltracking. Other complications while addressing a valgus knee.
Thank you for the wonderful talk, Dr. Bharath. It was to the point and precise.
So shall I stop sharing it?
Yeah. Do you have any more cases to share, or?
No, I think there are 3 other things they can share. I think so. If at all anything time is there, I'll share it last.
Okay. There are any questions? We can ask the questions now. Now, I have a few questions, Dr. Bharath. See that whenever we are so used to doing the femur first technique and the measured resection technique most of the times. So when it comes to doing a valgus knee with the same systems, sort of you are using a DePuy system here, so something like a DePuy system or whatever system we are used to. Now switching to this gap balancing suddenly is a problem because sometimes the instruments, the right instruments are not there, or we are not used to it. So how to go about this? Do you always do gap balancing in flexion for valgus knee?
It is not necessary. It is not necessary. If your landmarks you are able to appreciate, you are able to judge the rotation, it is definitely not required. So even if you could appreciate in the video, we attempted a measured resection. But what happens is you might have to correct it so that you don't have to release. So what Dr. Anavath used to say is that better avoid less soft tissue release to balance your knee in flexion. So that was the message he always delivers when I was there with him. He always used to say it in extension, that release, the soft tissue release is the one which is going to balance it. So if at all you wanted to balance your knee in extension, it's mostly the bony cut that you have to adjust to do it. And what I say is, even what I do by measured resections, but I end up with a gap balance. You understand what I'm saying? You have to correct here, you have to release here and there, you have to little bit adjust my bony cuts, you have to revise your cuts, thereby end up with a gap with a gap balancing technique. If your landmarks are completely lost, so you have no other options in this case. That will going to end up with a mismatch of your space, a more unequal medial and lateral space. So that might end up with a more constraint. Like you might end up with a TC3 kind of a implant.
So in a case with where the when balancing in extension,
yeah,
what soft tissue structures you release and what is your sequence?
Yeah, that's what is the sequence is what I have noticed in our experiences. If at all you have a flexion deformity, the first structures you have to address is your posterolateral corner. You release your PCL has to be released, then you have to release your posterolateral capsule, and then at last with the lateral capsule, then you might, if at all, if there is a hyperextension deformity of valgus. So once you are a distal femoral cut, after you might end up with starting with pie crusting of an IT band is the first structures to be. So what I say is your sagittal plane deformity. If it is recurvatum, you might end up with starting with pie crusting or IT band is the first structures. If at all, if it is associated with the flexion deformity, you might start with your with a posterolateral capsule.
So how do you release the posterolateral capsule? Do you release it in extension?
Yeah, I always release it once I make my proximal tibia and the distal femur. I put my laminar spreaders and then go release starting from the PCL, and then I release your posterolateral capsule and come up to the almost up to the posterior border of the IT band, leaving the space is quite less. But what happens, that is what has been said classically is, if it is a type 1 valgus, a normal standing view, if you could see, if the valgus is less than 10 degrees and then if there is no opening on the medial side, your bony cuts should be adequate. That is what, if at all you want to take 9 to 10 mm of a tibial cut, you have to take 9 to 10 mm. If at all, if the knee is lax, correctable, and if it is type 2, then only you have to go for a minimal bony cuts. If you make it to start with a minimal bony cut, then you may not have the space to go and release the posterolateral structures.
So you release the posterolateral capsule at the level of the tibia with a diathermy.
At the level of the tibia, I normally use my cautery to closer to the tibia, palpate the most hard structures immediately next to the tibial bone, and then release from, that is inside out technique. You come from the PCL to the posterior capsule, posterolateral capsule, leaving the popliteus. Popliteus is the last structure which I release. Then come up to the IT band, and then I start. Either I go for pie crusting with my cautery or I use 11 blades of the IT band.
You don't release the IT band at all, completely?
Not complete release. It depends. That's what I'm saying. Complete transaction, because it will leave your knee unstable if you release every structure from posterior to anterior. If at all you start with IT bands, if the posterolateral capsule is not required in hyperrecurvatum or type 2 or type 3 valgus, you might completely release your IT band also. That's not a problem.
So in a valgus knee, do you externally rotate the femur more or less?
Definitely not. That is the reason I use a floating technique. So I always, in a valgus knee, if at all I have a rotational issues, I go by a floating. I go for a trial insert 2 to 3 times. I flex and extend the knees. Then I mark the point with a cautery, and then I go for a tibial preparation. You're saying on the femoral side?
On the femoral side, the femoral rotation.
No. There is nothing called as a fixed rotation. Definitely not. Mostly it will be neutral or 3 degrees. There is no fixed criteria. You have to more external rotate. You don't have to. If you have a hypoplastic condyle, the reason why it has been said it is more, you have to external rotate more. It is, if you take the reference of your posterior condyle, which is hypoplastic, you have to keep more than, you have to compensate the hypoplastic condyle.
So you should not externally rotate more.
There is nothing. If you're taking that reference, if you have a shim, if you use it on the foot plate, if you have a small shim and if you use the foot plate on the lateral side of your referencing jig, then you don't have to really external rotate in all cases. Not required at all. There are situations we have used 0 rotations in a valgus knee. Zero rotations in a valgus knee. There is no fixed rule. Definitely there is no fixed rule in a valgus knee, because the reason is your soft tissue release is going to determine your space on the laterally, posterolaterally, or even if it is anterolaterally. So before soft tissue release addressing to such extent of you tend to rotate more, then you might end up with a problem.
Any more comments or questions from Arun, Satish?
Right. Actually, the approach will vary. Simply telling type 1, type 2, type 3 may be difficult to analyze. We have to analyze what are the components of the deformity. I will show you in my presentation how the categorization can be done. First of all, in a valgus knee, we have to categorize what is the fixed deformity and what is the flexible deformity. That is number one. That only will give us the idea what are the soft tissue structures we are going to release. Without analyzing that, it will be difficult. And roughly, the valgus deformity in extension is contributed by predominantly by IT band and posterolateral capsule. And the valgus tightness in flexion is contributed by the lateral collateral ligament and the tendon of popliteus. In severe cases, that will also contribute the valgus deformities in extension also. So this is the rough structures. Fundamentally, we have to understand that the lateral retinaculum, we are talking about tibiofemoral balancing. The other thing is the patellofemoral balancing. The lateral retinaculum is generally a tight structure in a valgus knee. You have to address that also. You cannot simply say it is tibiofemoral balancing and a rectangular gap. The lateral retinaculum is a tight structure to start with in most of the valgus deformities. Yeah, regarding this femoral rotation, and as I have always done only tibial first technique. Maybe in the 20 years, femoral first I would have done maybe 10 cases. Always it is tibial first. Always it is tibial first. Then do the distal femur cut. See that the extension gap is rectangular. Then you now put the 4-in-1 block. The 4-in-1 block, the inferior margin should be parallel to the tibial margin. That is the general thing what I do, even for a valgus knee. So valgus knee, it itself dictates the rotation. The tibial cut should be at the best. Again, in valgus knee, I always advise you should have a C-arm view. Like in THR, I always say in most of the early beginners, we should have a C-arm just to see where is the cup position alignment, even the placement of the implant in the canal. For valgus knees, you have C-arm with you. It will help you how good or how bad is the tibial cut, perpendicular. We think it is perpendicular, but many times it is not perpendicular. Because valgus deformity, as Dr. Bharath was telling, the patho-anatomy is complete. It differs from each and every case. It is not like a varus knee. In varus knee, most of the patho-anatomy is same in most of the cases. In valgus knee, the pathology to start with, it may be a dysplastic valgus, where the valgus is there from the childhood. So this patient will have enormous changes in the distal femur, the proximal tibia. He may be having 4-foot varus. He will be having proximal tibia is rotated and distal tibia is externally rotated. All these problems will be there. That is the dysplastic valgus. The other patient may have a osteoarthritic valgus. There is a physiological valgus and he gets arthritis after some age. The third category is rheumatoid arthritis. The fourth category is post-traumatic. You have to categorize this patho-anatomy first. So each and every patient will have a little bit different things. And we should know the anatomy, what is there on the lateral side. And contrary to what Dr. Bharath says, I won't say it is very difficult. Everybody does lateral plating of the distal femur. We have done many times. We are doing distal tibia plating now also. Same structures are there. As an arthroscopic surgeon, you have viewed, you have seen more better tendon of popliteus, all this thing compared to me, where I used to open. So it's all in the mind. It's all in the mind, and we can do lateral approach as easily, not as easily maybe. Once you get experience, everything becomes easy. It is not that difficult as it is projected. And this pie crusting will be possible only for a pliable structure. If it's a fibrotic structure, it is only tear. You have to be very clear on that. You cannot do pie crusting. You can do, say, pie crusting for the skin. How will you do pie crusting for tendon? Can you do pie crusting for tendon? So it depends on the fibrosity or viscoelasticity of the structure. So pie crusting will not work in IT bands. It's all only tear. You make 3-4 holes. The 3-4 holes will join and become a tear. That's all. So it is like an opening.
Right.
Do you want to
Completely
share?
agree, sir.
I just give a very
Cannot-
fancy term, that's all. And each and every patient is different.
Yeah, that's what I'm saying. Each and every patients are going to be different. Even I said rotations, you cannot go by a fixer that you have to extend rotate more in this kind of cases. It has to be individualized to that particular patient.
And when you do lateral approach, you do not bother too much about the rotation, because whatever you do, the patella will sit. You won't get a patella maltracking. But when you are doing medial approach, you have to be very careful on rotation. Even with minimal error in rotation, the patella maltracking will be prominent.
Sir, but what is your experience in the wound closure issues with the anterolateral approach?
I will show you there is absolutely zero.
Okay,
No,
you are able to
wound
close the
closure
retinoculum
wound
completely.
closure issue is zero. I had skin wound problem in my first few cases because I was putting my skin incision exactly in the midline. I never used this curved incision, what you have done. It's always vertical longitudinal incision. But after some time, I just shifted to slightly lateral. So the skin incision will be on the lateral one third of the patella, not in the midline of the patella. After that, there is no problem with the skin wound. I never had a closure, difficulty in closure, closing
On the
the
retinoculum,
process.
I'm not saying the skin, sir. I'm saying about the retinoculum
Process.
because
Yeah, processes you have to do. That is the arthrotomy that I will show you. That is the only thing. What you think it is a great technique? It is nothing. It's a 2 minutes thing.
Sir, you share the presentation, sir. We'll
Yeah.
go.
Yeah. Okay. Yeah. Yeah. Visible.
Yes, sir.
Yeah. Right. So this is a patient, 60 years old patient. Has got pain in the right knee for 7 years. He says the deformity is there since a long time, but he has observed increasing gait change for the past 2-3 years, and the pain has also increased. So this is the preoperative gait, and like we appreciate varus gait, we have to appreciate valgus gait. Everyone has to know what is an knock-knee gait or valgus gait, because this is one of the thing which pushed me towards the lateral approach. When I was in Chandigarh, we always tend to get patients for knee arthroplasty, and in the OP, many patients with valgus gait, I thought it is a post-operative patient, sorry, preoperative patient. When I go and see, I find that it's a preoperative patient. The valgus gait is persistent even after TKR in many patients where medial approach was done. Okay, this patient this is a preoperative X-ray. There is a significant degeneration on the lateral side. Not a very severe deformity, but the deformity was fixed. This around fixed deformity was 10 degrees, I will tell you. So now what we have to think of the valgus is whether this patient medial or lateral approach, and what is sequence of release with respect to tibia femoral balancing and patella balancing. So this is the most important slide. The valgus deformity, like varus deformity, can be contributed by flexible element and fixed element. So the flexible element is contributed by medial soft tissue laxity, that is a laxity of medial collateral ligament, and the lateral bone loss, which can be femoral and also tibial. Again, the tibial bone loss in early cases may be contained, but it always need not be contained. I will show you one of the cases where it is uncontained. And the fixed deformity is contributed by tight soft tissue structures on the lateral side. So as I said, the first structure is tight is lateral retinoculum, resulting in patellar femoral maltracking because the Q angle is increased. The patella is sliding on the lateral side at the time of flexion. And in extension, the valgus is contributed by tight iliotibial band, postlateral capsule, and tendon of popliteus and lateral collateral ligament that will contribute in both flexion and extension, more so in flexion. So the valgus, what we see in an outpatient department, is what I term as clinical valgus. The patient is standing, you get the deformity. The deformity is a maximum deformity what we get. That is clinical valgus. Our patient is standing. So clinical fixed valgus is you make the patient lie on the bed in your clinic and you give a varus stress. Now that some of the deformity may get corrected. So that shows that there is either a medial laxity is there or lateral bone loss is there. But whatever the tight structures on the lateral side, that can be painful and you will not be stretched beyond a point. Now you do the same thing in the operation theater. After giving anesthesia, you give your varus stress on the extended knee. whatever the residual deformity you get, that is a true valgus. You can say real valgus or a real fixed valgus. What I call the surgical valgus. So surgical valgus gives you how much you have to release the tight lateral structures. So that it represents the tight, unyielding lateral soft tissues with respect to the tibiofemoral joint. So these are the different pathologies. I said osteoarthritis, rheumatoid, dysplastic, post-traumatic. So based on what are the tight soft tissues and what is the on the lateral side, what is the bone loss on the lateral side, and what is the medial laxity. A patient who has got clinical valgus 25 degrees can have a clinical valgus of say 10 degrees and surgical valgus of 5 degrees, or the surgical valgus of 0 degrees. We can have any number of permutations, combinations. This is the most important thing what we have to know. Medial laxity, lateral bone loss, lateral soft tissue tightness. So if the surgical valgus is more, you have to do more lateral soft tissue release, and then the lateral approach is handled. So when I do lateral approach, of course, it's all, as I said, it is not fixed thing. Whatever you are comfortable, you can do. I have seen hundreds of cases done by medial approach by my professors. As I said, post-operatively, the deformity correction is not optimal. Patellar tracking is not optimal. Knee flexion is not optimal. The post-operative gait, when the patient comes after 2 years, they have persistent valgus gait. So it made me to think, and also I am a deformity correction surgeon. I don't call myself as arthroplasty surgeon. So it is very logical to treat the deformities, whichever is tight, better to approach on that side. So I do lateral approach whenever the surgical valgus is more than 5 degrees or 10 degrees. Generally, I like to do by the lateral approach, unless otherwise, if it is 0, surgical valgus is 0, I go for the medial approach, provided pre-operative X-ray do not show patellar maltracking. And dysplastic valgus deformity is an indication, and posterolateral bone defects and valgus associated with fixed flexion deformity or valgus associated with stiffness. Stiff knee means you cannot bend the knee say beyond 70 or 80 degrees. Why? As I said, it is a direct approach. Part of the needed soft tissue releases can be done. The tight lateral tissues can be properly visualized. It can be sequentially released. As Dr. Karthik was asking, what are you going to do? So if you go on the open side, you will see what are they want to release. When you do on the medial side, it's difficult to see. So what we do on the varus knee, you can very well see the medial, anteromedial capsule and posteromedial capsule. Same thing you will see the IT band and you will see the posterolateral capsule on the lateral side. And excellent patellofemoral balancing you can do with all grades of deformity. So this patient, our patient, the anatomical femorotibial angle was 19 degree valgus. Normal is 5 to 8 degrees, and when you make these angles, so these are the standard deformity correction thing. DrBRJSathish book, it is there. We can apply to all deformities, including knee replacements. And here the mechanical lateral distal femoral angle is 80 degrees. Normally it is 87 degrees, and the mechanical medial proximal tibial angle is 93 degrees. So contrary to the popular belief, the valgus is contributed more. It's not only by distal femur. In this patient, you can see approximately 6 degrees is contributed by femur, approximately 5 to 6 degrees is contributed by tibia, and 1 degree is by the medial laxity. The mechanical axis deviation, we can directly measure. This is 4.9 centimeter. Normally, it is 0 to 8 mm, whereas here it is 4.9 centimeter valgus. So this is explained by Kablish. So this is what is called expansile lateral arthrotomy. You are not going to cut the lateral retinaculum as a single layer. You consider this as lateral retinaculum capsule complex. We are going to divide lateral retinaculum from the capsule. We are making to do it as a 2 layers, what is called coronal Z-plasty. So this patient, you give a midline longitudinal skin incision, not on the centering patella, slightly on the lateral one third of the patella. You have to make a big lateral flap like this, and then you can mark. So this mark is close to the patella, and this mark is on the lateral retinaculum capsule complex. So now we are going to release this slowly in 2 layers. You just consider that it is two layers, anterior layer and posterior layer. You can think like I am releasing the anterior retinaculum from the underlying capsule and synovium, but they're all blended. So this will be some 1.5 minutes. You can just see, because this is the most important step of this entire procedure.
You start releasing from the patella or from the lateral aspects?
Lateral aspect, lateral aspect.
Why not?
You can see.
Why not from the patella?
No, we cannot do that. You will see, because only if you do like that, with the posterior or with the deeper thing, you take all the fat. And we want to approach the joint. So if you do like that, it will be difficult to approach the joint on that side. And here we want to keep this anterior one in continuity with the patella. Now I have opened the joint. And distally, you take all the fat with this deeper or posterior layer and releasing this iliotibial band. Everything you work superiorly like you do on the varus deformity. So you can see all fat and the IT band is getting released. So everything, this is all these steps is there in Essential Surgical Technique. If anyone is interested, you can read that Essential Surgical Technique article. Completely all step by step is there. And first time you may find it difficult. Here also you can say I am just doing a little bit oblique cut on the lateral tendon retinaculum area. I'm doing a little bit oblique cut. Right. So distally, the IT band and the proximal lateral anteriorly, the capsule, everything, even the lateral meniscus, nothing we are going to exercise that. We keep everything there. And then work close to the bone. You go up to the mid-posterior margin, up to the posterolateral capsule, you release. And once you do this, most of the time, the deformity is corrected. Now we extend and see, the lateral side will open. Yeah, so you can see here clearly, this is this anterior flap. This is the posterior flap. The joint is not open here. Now this joint will be open close to the patella here, the deep one. So this is like two layers. You're just separating. So here the IT band is released, and the thing is we need to do a quadriceps snip for better exposure. Again, a lot of people think that this is a very great problem. Unless you have done a revision TKR, this is not a problem. Quadriceps snip, this will heal very well. Yes, patients may have some quadriceps lag in the first 3 to 6 weeks, but that's all highly acceptable for me, because I'm going to do optimal tibiofemoral balancing and excellent patellofemoral balancing, and is doing a quadriceps snip it's a relatively small price for me. And how do we expose the joint? Joint exposure normally is invert the patella, flex the knee, and externally rotate in a varus. Here we are going to do internally rotate. This is called reverse insult maneuver. You hyperflex the knee. Now after a quadriceps snip, you can invert the patella, and you can see here that is internally rotated. Yeah, you need to have a little bit different orientation, but again, not very difficult. And especially if you are a trauma surgeon or arthroscopic surgeon, it's not very difficult. So you can see here proximal tibial.
Yeah.
And this patient can see it's a typical posterolateral significant defect, the cartilage loss on the femur. So the proximal tibial cut is done, and when the proximal tibial cut is done, we see that rather than taking the, you can see here it is clearly written, it is written as left. The tibial block is left. Because this has got more cutting on the lateral side. Normally the tibial block right will have more cutting on the medial side. That is not going to make any change. And this was the step I was telling, if necessary, you can use C-arm. This cut should be perpendicular to the long axis of the tibia. If you hear that is a problem, so this cut should be perpendicular along the tibia. And You can take, if there is no hyperextension, you can take the normal cut from the normal side. I mean the medial side, medial tibia. Probably you can take 9 mm and you can start with 7 mm. If necessary, you can take it later. It is not that you have to always take, because we are already approaching from the lateral side. As Bharath was telling, it is not that you have to take sufficient cut to reach the lateral side. Many of you can understand, even in a normal varus knee, it is difficult to reach this posterolateral corner. All of us have struggled to reach this posterolateral corner in a normal knee to put the tibial implant. Now, in a valgus deformity, you say, I will reach this easily by medial side. I really cannot appreciate that. Without stretching more on the medial side, without externally rotating the tibia more, again, the medial side, you are doing more and more laxity because it is already lax. By this procedure, we are internally rotating. We are not touching anything on the medial side. And what we call this pathological posterolateral corner will come into your view. And you can see the complete distal femur lateral view. Right, this is the distal femur cut. Like any other thing, you can see that the distal femur, after taking the cut, you take very minimal cut on the lateral side. You take cut only on the medial side. And as Bharath was correctly telling, you have to.
Oh, that's another track, man.
I think someone has to mute.
Yeah, please.
All the participants. The entry point can be slightly medialized. Again, it is not mandatory. In post-traumatic valgus, this patient was having a normal femur from the beginning. The valgus has developed only after trauma. So you can take a normal entry. That's why I told, if you have any doubt, you always have a CM and check that where it is. And preoperatively, you always check what is the relation between the anatomical axis and the mechanical axis of the femur. And generally, in a valgus knee, we like to take slightly less. In a varus knee, you can take 4-5 valgus. In a varus knee, we take a distal femoral cut 3 degrees with respect to the mechanical axis. And once the distal cut is taken, you check the extension gap. If this is rectangular, means your deformity is corrected. Overall, you can see the alignment. If necessary, you can do the posterior capsular release. You can go further posterior. So normally you do not go to the posterior, complete posterior side of the lateral tibial condyle. If you think it is tight, you can go up to that. You need not release tendon popliteus and LCL unless otherwise in very severe deformities. Then we take the femur 4-in-1 cut. As I said, so this implant, you can see this line in the implant. You can see the line in the tibia. This is parallel. So this is the single most thing. Many times you are not able to see the lateral epicondyle, and that may also show a little bit wrong thing if your things are sizer is not seating, but you have to put shimmer if necessary, and or you can put even a saw blade. You see that this is parallel to the tibial cut, and then you fix the block. And even without, I am telling, and see, there is no, we have not put the spacer. You can see that this is parallel. The flexion gap is rectangular. So conventionally, you can see it is a sclerotic, and you put multiple drill holes on this side. And then you put the trial implants, you see the deformity is fully corrected. And you can see this is the right side, lower limb, the patella is on this side, medial side. So we have approached from this lateral side. I do surgeries, all surgeries standing only on the right side of the patient. Only the lateral approach, if I do on the left side, I will go on the left side, left side knee, I go on the left side. Otherwise, I always do left knee, medial approach also I do from the right side. So orientation, it's all depends on the surgeon, and you will get oriented easily. So this is the implanted. And the quadriceps snip is repaired in extension. You have to do a robust repair. And before doing a quadriceps snip, I always take a marker with a vicryl, so that it is very easy to trace back and do it. And you can see the knee is flexed 90 degrees. This is called excellent patellar tracking. And I will say that this patella is sticking and kissing the femoral condyle. This will not happen in medial approach. This will not, and this cannot happen in medial approach. The moment we correct the deformity, we do everything correct. If you correct the valgus into neutral alignment, the Q angle changes, the patella is shifted slightly medially, and automatically there will be tightness, and there can be some element of maltracking, and most of the time they end up doing the lateral retinacular release. They say pie-crusting, but many times it will be a complete release. So what I have termed in my article as it is bilateral or double arthrotomy. So rather than doing a double arthrotomy, why not to do a single arthrotomy on the lateral side? And this is the expanded area. And you can see here, this is the margin patella. So you can see how much the patella has been shifted on the medial side. And this ink mark, you can see that is the medial margin of the patella. Sorry, lateral margin of the patella. So from there up to here, we have got one layer. And from here, the stitched area to here, we have got another layer. So the prosthetic joint can be completely closed in all the cases. If you do this, there is absolutely, it won't be visible at all. Otherwise also, again, as I've written in my article, what you are doing in a medial approach, you do a complete lateral retinacular that is open on that side. So you have got only skin on the lateral side beneath the implant when you do a complete lateral arthrotomy for the patellar tracking. So you have doing arthrotomy on both sides. That is always, I have seen many patients, the skin is so thin on the lateral side if it is done on the medial approach because it is directly lying on the implant. So this is what is called the expanded area. This is the postoperative X-ray. And this is the postoperative clinical thing. And this is the postoperative video. So this patient has taken from his home and he has sent. So I always ask the surgeons, are you happy? What is your happiness quotient after doing a valgus knee? Are your happiness is equal to that of after doing a varus knee? I can see my own professors. I have seen that the moment valgus knee is on the table, they are a little bit tense. They are not happy at the end of the procedure. So I have also done few valgus knees by medial approach. I was never happy. Happy means it is fine. Patient is not having pain. But the satisfaction at the end of surgery, what you get after doing a varus knee by medial approach is not equal to the satisfaction what you get after doing a valgus knee by a medial approach. So this is the original clinical article, and this is the surgical technique. It is available freely. If someone is interested, you can go through that, and you can always ask me if you have got any doubts. And this is a patient where you can see the uncontained defect on the left side. This is a wind-blown knee, and both sides he has a defect. He has got a defect medial side on the tibia and the varus knee, and the lateral side on the valgus knee. So how will you approach this defect if you do on the medial side? I think it's impossible to approach this defect on the medial side. And I have just done only bone grafting, and it has incorporated this is a 5-year post-op for that patient. So in conclusion, valgus TKR is challenging. It is not just the reverse of varus TKR, and we have to understand it is different in terms of pathology, in terms of anatomy, and you have to consider that as a deformity correction approach, and balancing is paramount not only for the tibia femoral, but also the patellofemoral. Right. Okay, thank you for your attention. If you have got any queries, you can ask. Yeah.
Sir, do you do Smith in all the procedures? Cordyceps Smith?
Yes, if I am doing a lateral approach, I will do. It's a part and parcel of the procedure. As I said, you will have great hesitancy in thinking like that, but I don't have any hesitancy. The hesitancy will go off only once if you do for a few cases, because the quadriceps tendon is normal most of the time, and you are going to do a robust repair.
So and your mobilization protocol doesn't differ when you do a
doesn't differ. Most of the cases we can, as I said, tibia femoral balancing is excellent, and you can get a mostly straight knee, and the gait will be much improved in patients. We are not accentuating the existing deformity.
Excellent talk, sir. Excellent demo and explanation. After hesitating a lot, I did a couple of knees through the lateral parapatellar approach, and I found it extremely easy to balance the knee, valgus knee. But the only thing I did was I did the reverse lateral flap. I actually
reverse lateral flap, Karthik, before you tell, I will tell. Reverse lateral flap is done for lateral patellar stress syndrome. That was the thing. It was done in 30-40 years back. It was an open procedure. for patellofemoral pain, it was done. From that, it has been copied. Then only I know. Recently, there is an article that compares arthroscopic, this release, lateral release, open release, single release. I mean, it's a cut, or this release, this slide release. There they do from, as you said. Yeah.
So for the varus knees, when the patella doesn't track properly, I do this coronal
Yes.
coronal lateral
yeah.
lateral release, and so I did the same thing. I didn't know this actually. I probably missed that in your article. I didn't know we have to do it from the side. So I did from the other side. It seemed to work quite well. The only thing is I didn't do the quadriceps snip, so I had some difficulty in everting the patella. What it was, I just left the patella there on the. I didn't evert it. I just left it on. Just like sometimes we do in obese knees where we don't evert the patella.
Yeah. So because you are customized to do femur first, you get some space. But I'm doing a tibia first. It's very difficult to get some space without everting the patella.
So for us, we do
the other reason, Karthik, here when DR sir was doing is because he's kept a significant amount of retinaculum attached to the, because double layer plasty is doing. What happens is the entire mass you cannot shift it to the medial side. So you do not have an access to the femur. So he has to do a quadriceps snip to have a more room of space. If at all, for example, the one video which I showed you, we were a little bit closer to the patella without a quadriceps. So you have a little more room if you are. But we had problem is we are not able, sometimes it's not possible to get the approximation of the retinaculum closer to the patella. Okay.
Cannot.
So we used to go into a single layer into it and release into take it as a one complete sleeve. Whereas what Dr. Bharath has done is he has made a kind of a plasty, that
So
two layer.
the
closure was not a problem at all for him.
The layer may appear very thin. I think we will not bother because that becomes thick after some time. The layer may appear very thin, but it becomes thick. And compared to the varus knee, if you see in a severe varus, the proximal tibia will remain open. You cannot close MCL in severe varus. So similarly, in some of the most of the valgus, if you have done correctly, you should get a defect in the lateral distal femur. You have to get. That means you have corrected the deformity correctly. So that we are going to close with these layers.
Sir, when we do the varus knee, as you said, we see the entire medial side and we do a subperiosteal release of the medial aspect up to the middle, up to the midpoint.
Yes.
Sometimes.
Yeah.
So we can do the same thing in the lateral.
Same thing. Yes, same thing. So you need not go to the, as I said, you go start from the anterior side. Anteriorly, you have got IT band. Now you go to the what is called the mid lateral. That is, you have got the lateral capsule. You need not go to the much posterior side unless you have got tightness in flexion.
Okay.
Same thing. What you do on the varus side. See, the principle is very similar. You are not going to touch the capsule which is attached to the posterior most side of the tibia unless you have got a problem in the flexion balancing.
It's a sequential release. You assess every release.
And because you see the structures, you are more confident. I had one or two cases of perennial nerve palsy with the medial approach, even with less deformities, because there is no space on the lateral side. You keep on give traction, you try to push your spacer, and you just blindly put the holes, and where the hole goes, nobody knows. Here you are more confident, and initially I used to do release of the nerve also, but now I have restricted to only the valgus is associated with flexion deformities. Otherwise, even in severe valgus deformities, I do not do nerve release now. If it is associated with flexion deformity, valgus plus flexion, then we can do. And valgus, with even osteoarthritis valgus, to remove the osteophyte on the lateral side itself is very difficult from the medial side. So this is a roundabout approach. That's what I really do not know why surgeons want to always do from the medial side, and with great difficulty do. Even many varus knee obese patients, to reach that area is very difficult. Posterolateral corner is very difficult to put the tibial implant.
Nice. I think it's just the familiarity with the approach and
yeah, as I said, you will not get worried. You have done distal femur plating, lateral side. We have done proximal tibia plating, lateral side. Yeah.
Fantastic, sir. Thank you very much. That was a great value addition. And Arun, do you want to present your case?
Yes.
Yeah, sir, good evening. Nice talk from Bharath BRJ, sir. So I'll just go on with the case presentation. 59-year-old male, no comorbids. I think this. Can you see, Karthik?
Yeah, I can see. Yeah,
So this is who he was.
I can see from his dress is that he's from Bangladesh, from your place.
Yeah, he was indeed from Bangladesh. Yeah. So these were the X-rays. So for all my valgus knees, I do these stress use, especially to look for the MCL. So here, even though the deformity was severe, it was more like a bony defect that contributed than the MCL. So MCL was intact. Lax, but not gone, even though it's a type 3. And also get a the Merchant's view for all these knees to see the patellar subluxation. So here you can see that both the patella are subluxating laterally. And then, so I was doing most of my cases or all my cases through medial parapatellar initially. Then I happened to listen to Dr. BRJSathish Coimbatore. I think this was about maybe 9 years or something back. That is when I started seriously looking at lateral parapatellar. 2015, I've been doing lateral parapatellar. Initially, I did it for even moderate and severe valgus knees. But then over time, the same problem Dr. BRJ sir was saying, like, I think it gives rise to some amount of extensor lag in when we do the quadriceps snip. So now my sort of approach is most of the if patella is not subluxating, then I am able to release through the medial parapatellar. If patella is subluxing, then I go for the lateral parapatellar. So for this patient, this was the time when I was doing all lateral parapatellar, did him lateral parapatellar. So both knees were done in a single stage. Yeah, lateral parapatellar, like what Dr. BRJ sir was saying. I did a coronal flap of the lateral retinaculum. I did a quadriceps snip. We can see a good exposure of the lateral side as well. So femur cut in 3 degrees valgus, 5, tibia cut in neutral, 6 mm of the medial side. And so this was the release so if you've done a lateral side, then most of the time the iliotibial band is sort of released. You just pie crust it a little bit on the mid-coronal region. Then you get the popliteus exposed, and just below the popliteus, release the capsule perpendicularly off the tibia with the laminar spreader. Here you can see the laminar spreader is placed with the knee in extension, popliteus clearly visualized. And then you go and release the capsule, just taking care not to go deep and keeping your hand on to feel for any nerve twitches. So once the balancing in extension is achieved in flexion, balancing through rotation, like Bharath was saying. I have even for varus knees, I don't rely much on the epicondyles. Somehow I feel I'm very accurate with mapping out the epicondyle. So I use generally a gap balancing method. Same for varus knees, same for valgus knees. So in the left knee, it was slightly more simple. So in fact, I try to retain the PCL if I can achieve good balance in extension. If it is still not getting balanced in extension, I take off the PCL and use a semi-constrained varus valgus constrained implant. For the right knee, as shown here, I had taken off the PCL, used a semi-constrained varus valgus constrained implant. On the left knee, I had a good balancing with soft tissue releases alone, so I was able to. I did retain the PCL. So this was the balancing inflection. As I think one of the best advantages of the lateral approach is the patella tracking, as Satish also showed. So patella hugs and tracks on the femoral component really nicely. This was the left knee. You can see from the lateral parapatellar approach. So this was the post-op clinical picture and post-op X-rays. The right knee had a varus valgus constrained implant because it did open a little bit more medially even after the releases. The left side was a CR knee. And this was the post-op scanogram. And this was him walking around 6 weeks.
Fantastic work, Arun.
Yeah.
Fantastic.
Yeah.
So,
So I must thank Satish sir for sort of introducing. I am sure I happened to be just a listener in the talk from where I started.
obviously, introduced it to several people. Yeah, and it is.
Arun, you have done both sides lateral approach or?
Yeah, sir. Both sides lateral approach, sir.
Arun,
Right side,
the one
right
thing.
side, the insert seems to be, sorry, right side, the insert seems to be thicker. Probably that is because you have taken more tibia or because left side it seems to be fine, but right side the insert seems to be thick.
Yeah, sir. I used the varus valgus constraint insert, so the minimum size is we got is
Okay.
11. Yeah.
Right,
So minimum size we have is 11. So I took 2 more of the tibia.
And another thing I just want to tell, as I said, this is a dysplastic knee. This is there for multiple years. All the ligaments are adjusted. I think Karthik can understand, as orthoscopic said, the ligaments are getting adjusted to the bones for such a long time. Now you change everything. You want to give PCL, and that doesn't make any sense for me actually. You have to use a regular PS knee in such cases. It's a dysplastic knee. You can see, patient has got that deformity for a very long time. Yeah. Better to do a PS knee unless the knee is normal. Otherwise, for example, a post-traumatic knee, you can try to retain PCL if it is fine, because this is a normal anatomy from the beginning, and you are going to retain that PCL. This is abnormal anatomy, and you are trying to correct the anatomy. In that corrected anatomy, that PCL generally it will not work.
So 2 questions on the PCL. One is, so PCL is a secondary constraint on the medial side. So in sort of grade 2 valgus, I mean, taking out the PCL, sometimes I feel it increases the medial laxity a little bit more. So in those cases, I feel retaining the PCL helps. And second thing is hyperextension deformities. So if you take out the PCL, then the extension gap also increases sometimes.
Yeah, that's right. But as I said, that the PCL was there in that abnormal angle. So this PCL in the new angle may result in 2 things. One is pain while doing flexion. The other thing is less flexion. And many studies have shown that if you retain the PCL in such situations, there will be paradoxical, what is called anterior rollback, rather than the normal posterior rollback.
Yeah, that's been on the CR knees for a long time now, sir. Yeah, that's true. Yeah. So yeah, I mean, we try to make sure that is the
Yeah, just telling. So it is, as I said, it's all ultimately functionally patient may not have long term. It's not much different between CR and PS, but these are just the views. Yeah.
Yes, sir. Do you use PS for all valgus knees or depends on cases?
Bharath,
I use PS for most of the valgus cases.
Valgus knees.
Arun, the one thing I want some clarity is if the knee doesn't balance in extension, you remove the PCL. Is that what you said?
No, I mean, I generally, it is either a varus valgus constrained knee or a CR knee that I am trying to put in the severe valgus knees. So if you want to put, I mean, if it is not balancing well in extension, then I mean, despite the releases, then I go for a varus valgus constraint knee. So that is what I have done on the right side for him. If you want to do a varus valgus constraint knee, then you have to take out the PCL. Yeah.
Okay, it is not because the knee is, I mean, tight. The knee is it's because of the medial laxity. You are worried about the medial laxity rather than the lateral tightness, right?
Yes.
Okay. Excellent. I think we had a very fruitful discussion and lots of learning about valgus knees from the masters. Dr. Bharath gave a very concise and algorithmic approach to the valgus knee, and Dr. BRJ, the teacher of all of us, so he's given us a complete covered the entire valgus knee in his own style, inimitable style. So thank you very much, Dr. Bharath, Dr. BRJ, and thanks Arun for an excellent case. We had a case as well, but I think very similar, and we did the lateral parameter approach. So that's the same thing. Any more questions? Any questions?
Yeah, thank you, Karthik, and I'm really happy to see that many are doing lateral approach, because when I started lateral approach 15 years back, they are just saying Miki, that I have come from Mars, and they are all telling this spike cresting, all this blah blah blah. Because I do a lot of deformity correction I have done in children, so it looks sensible to approach the deformity on the tighter side. That's all. That's how I started, and as I said, the deformity correction will be very good, and you will be equally happy, like when you are doing a varus after doing a valgus, and you won't have that anxiety or tension. Normally, we will be tensed up when we do some of the cases, and that some of the cases, one is valgus knee, one is fracture neck of femur, something like that. So here you don't have anxiety when you start doing that.
Right. Thank you very much, sir. Thanks for the participation. If there are no more questions, we'll call the session to a close.
Thank you, Dr.
Thank you,
Bharath and
Karthik.
Dr. Arun. Yeah.
Thank you, VR.
Thank you.
Thank you, Arun.
Bye.
Thank you.